Sound check, sound check. Hi, folks. Professor Gulliford here. We need to wrap up chapter 10, which we didn't get to finish at the first of the week, and we need to also go ahead and get chapter 11 recorded for you. Excellent work on the midterm, excellent work on the case studies. I see a lot of people on the way to an A or B in this class, and that's wonderful. So let's go ahead here and go ahead and look at the PowerPoint. Where is the PowerPoint? There it is. It is a breathing patterns all on one page. Normal breathing, apneustic, ataxic, biots, Schoen-Stokes, and Kussmaul's. So that is very much the pattern that you need to recognize. Those are the ones that are likely to show up on board exams. I wonder if I could post that in the course easily. Let's see if I could. I could probably just copy it onto a Word document, or maybe even into just into an announcement. I've got it copied, and I'll see if I can get that done here after we record. Cerebral cortex is the portion of the brain that can override involuntary ventilation. That is, you can decide to breathe deeper or faster, make a conscious decision about that. And we ask patients during a pulmonary function test to do exactly that. Take their deepest breath in, blow out hard and fast. Voluntary hyperventilation, voluntary hypoventilation are possible. However, there are some protections in place that if it gets too far out of whack, the involuntary aspect will take over. I don't know if you ever did the thing where you hyperventilate until you get dizzy just to see that what that feeling is like. I think a lot of people growing up at some point did that. And if you hyperventilate sufficiently, you'll pass out, and then the involuntary mechanism takes over, and everything will be okay. And I don't think anybody could ever actually harm themselves unless they were by just falling, you know. Decreased PaO2 has little to do with ventilation. It is the high CO2. Elevated CO2 is what motivates us to breathe. So you need to understand that it's the primary stimulus to breathing. The limbic system, which controls emotion, memory, and stimulation, structures like the amygdala and the hypothalamus interact, and they do adjust ventilation in response to real or perceived threats. Being scared, someone chasing you, let's say, or thinking that someone is trying to get you, whether it's true or not, does affect your breathing. Blood-brain barrier separates the central nervous system from anything that's circulating through the body. And very few things actually cross the blood-brain barrier, but a few do. And we're very interested in the carbon dioxide, hydrogen ion, and bicarbonate in the cerebrospinal fluid. That's partly how the brain comes to realize that you need to breathe more or less or make whatever adjustments need to be made. So it is the CO2, again, that's your primary stimulus to breathing, hydrogen ions, and bicarbonate that cross over the blood-brain barrier from the cerebrospinal fluid. CSF itself, you will see this sampled in a spinal tap. And cerebrospinal fluid is a clear, colorless fluid, surrounds the brain and spinal cord. We can test that for a lot of different conditions, including meningitis and encephalitis and some pretty serious conditions. Fortunately, we're able to get that sample relatively easy from the patient's back between the vertebrae. The brain receives signals from various types of receptors. Chemoreceptors are the ones that are looking at pH and CO2. The fluid may be blood, cerebrospinal fluid, extracellular fluid, and we have central and peripheral chemoreceptors that are constantly monitoring and helping us to get that right. We don't have to consciously think about it. Central chemoreceptors are in the medulla oblongata. We've talked about that structure before. It is probably the key area for breathing. And what they're looking for mostly is the hydrogen ion concentration, which is the pH. That's just kind of a fancy way of saying the pH. And that is what motivates the patient to breathe. It's because of resulting changes in CO2. Might as well just mention this while we're on it. As the CO2 goes up, the pH goes down, and that change is what is recognized. If the pH goes below 7.32, now the normal range is 7.35 to 7.45. If it falls below 7.32, the central chemoreceptors kick in to increase ventilation. Okay, and that is what's going on right there. You see the central chemoreceptors, they are sensing the hydrogen ion concentration, meaning the pH, and then, adjusting ventilation. The key number seems to be 7.32, where that is kicked in. When CO2 falls, when it goes the other way, then the central chemoreceptors sense this, and they will actually decrease ventilation. So very much it's dependent upon the hydrogen ion concentration, the pH, in the cerebrospinal fluid. Various external factors come into play here. For each 2 millimeter increase in CO2, alveolar ventilation increases by about 2 to 3 liters per minute. So it's a pretty tight response mechanism. It runs a tight ship, you might say. It doesn't let the CO2 change very much from the patient's own normal. Now, absolute normal is 40, but many of our long-term patients have CO2s in the 50s or 60s all the time. So it's just going to be that way, and it becomes their normal. So we get increased CO2 in the blood, and then the cerebrospinal fluid, then increased hydrogen ions, that's the pH, decreased pH, increased stimulation of chemoreceptors, increased ventilation, decreased hydrogen ions, increased pH, and decreased stimulation, decreased ventilation. So that little circle is always going on, keeping our pH in a safe range and our CO2 in a safe range. The oxygen really doesn't kick in until it's a serious situation with low oxygen. Where are these peripheral chemoreceptors? They're in the carotid bodies and the aortic bodies. Yeah. Carotid bodies also respond to decreases in arterial pH. That just shows you the location right there in the neck. Carotid bodies. When the patient has an extremely high heart rate, certain kinds of tachycardias, we can sometimes stop those by stimulating, massaging the carotid bodies there. You'll see the ER doctor doing that, and often it does in fact work because it tricks the carotid bodies into thinking that the blood pressure is high and that they ought to slow down the heart. Yeah. PaO2, a key number is 60. We say in respiratory, 60 gets you 90. So I'll just add that to the slide here. 60 gets you 90. That means 60 on the PaO2 gets you 90% saturated, which is a good place to be. Anything over 90 is generally considered acceptable saturation. But our medical director says this is a slippery slope because if you drop from 60 to 50 on the PaO2, the oxygen saturation is dropping substantially. It's a downhill slide. This thing is called the oxyhemoglobin dissociation curve, and we will come upon that later in the course. Peripheral receptors also responsive to changes in CO2. Notice how seldom we mention oxygen here because the PaO2 is not the primary mechanism. It's the PaCO2. Pulmonary stretch receptors also come into play. What they do is they sense if the lungs are overinflated or underinflated, and they send a signal back to the brain to, adjust that. When you have an area of atelectasis, meaning microcollapse, alveoli collapsed in the lungs, then that reflex kicks in to get the patient breathing deeper and expanding those areas. Herring-Brewer inflation and deflation reflexes also help us to, keep our lungs properly inflated, not overinflated, but properly inflated. Normal tidal volume for most of us adults is, 500 milliliters, something close to that, 400, 500 milliliters. But this reflex kicks in at about 1,000 milliliters. So that's a pretty deep breath. Head's paradoxical reflex is partial blocking of the vagal impulses. How much have we talked about the vagus nerve? Partial blocking of the vagal impulses associated with Herring-Brewer. So it's like the counterpoint. If Herring-Brewer is the point, Head's paradoxical is the counterpoint. It sort of balances against the Herring-Brewer inflation. Irritant receptors have vagal sensory fibers, and they will respond to any noxious chemical coming in, dust, smoke, whatever it may be. When stimulated, the irritant receptors send impulses from both sensory and motor neurons, and they produce what's called a vasovagal response, which is really pretty interesting. It happens a lot. We have to be very careful when we're suctioning, because when we suction, we may be stimulating that vagus nerve and causing the patient to have a significant response. Bradycardia is the one that worries us. I remember a patient whose heart rate went from 80 something to about 30 when I was suctioning that patient. So stop suctioning immediately and then give the patient a chance to recover, and then report to the doctor what happened. J receptors, yeah, also called pulmonary C fibers, are located in the small airways. The J receptors are supplied by blood from the pulmonary circulation, innervated by the vagus nerve. They send impulses along the vagus. How many times we said vagus? And it does things like shallow breathing, a narrowing of the glottis during expiration. And there we go. Bronchial C fibers are similar. Their stimulation results in rapid, shallow breathing and increased mucus secretions. So all this is going on to regulate your breathing, and we don't even have to be consciously aware of it. I'm going to get a sip of coffee here. My fall allergies have been worse this year for some reason, probably because we had so much rain. We had a bunch of rain in Oklahoma this year compared to a typical year. Okay, upper airway receptors are a type of irritant receptor. When stimulated, they send impulses, eliciting a variety of responses: bradycardia, rapid inhalation, hypertension, bronchoconstriction. Peripheral proprioceptors. This is interesting. What these proprioceptors do is notice increased movement, like when you start to run. When you start to run, your breathing increases quicker than your need for ventilation increases. So just the movement is telling your central nervous system and then your lungs that more ventilation is needed. Yeah. So pretty interesting. Proprioceptors, they notice your movement and adjust your breathing. Muscle spindle fibers also monitor elongation of muscles, so they will adapt to the demands like an exercise session or weightlifting. Arterial baroreceptors are pressure sensitive in the blood vessels, and they notice blood pressure that's too high or too low and send signals to adjust that. As arterial blood pressure rises, the walls expand. That increases the frequency of impulses, and arterial blood pressure responds to that. So it's an amazing mechanism, actually set of mechanisms, I would say, that keep all of this straight. This we've mentioned before, the VQ ratio, the normal ventilation perfusion ratio. Students have asked me for years, why the Q? Wouldn't it, be VP or something else? But VQ, Q is the quantity of blood flow. So normal ratio is 4 divided by 5, so it's 0.8. That's going to come up in quite a few of your calculations for future courses. And there it is, 4 liters of ventilation, 5 liters of blood flow. That's a very typical VQ ratio of 0.8. That's a number worth remembering. It's worth remembering just because it comes into play for so many different things. Yeah. And there it is again, 0.8. It's sort of an average. We know that the VQ is different in different parts of the lung, but zero point 0.8 is what we're going to call the average. Let's see here. Normal blood oxygen is 80 to 100. Every therapist needs to know that 80 to 100 is considered normal, which gets us about 95 to 100% saturated when we study that by pulse ox. Hypoxemia is where there is not enough oxygen in the blood. And this can be due to diffusion problem, hypoventilation, shunting, VQ mismatch, any of those things. Diffusion limitation, something like pulmonary fibrosis would be a good example of that, or emphysema. Hyperventilation, increased ventilation, often in exchange for, or actually caused by, a low oxygen level. Your body's trying to get more ventilation so that it can get more oxygen, and that results in hyperventilation. So on your boards, if you see a question where patients hyperventilating, check their oxygen level because they may be stimulated to do that. Hypoventilation will also have hypercapnia. That is a increase in CO2. That word you need to definitely know. Hyper, excessive. Capn, CAPN, is CO2, carbon dioxide. Hypercapnia, an increase in carbon dioxide. Hypoxemia, additional oxygen inhaled will raise the PaO2. Supplemental oxygen does not influence the CO2. Respiratory depression related to certain medications is an example of hypoventilation. What we do see is that sometimes patients will accidentally overdose on their pain medications after surgery, and that results in respiratory depression, an example of hypoventilation. Hypoxemia may be caused by pulmonary shunt, and that is the occurrence of unoxygenated blood from unventilated alveoli mixing in the pulmonary circulation. You'll learn a lot more about shunt in the courses to come here. All right. Let's see here. Occurrence of hypoxemia in response to low alveolar oxygen levels can trigger hypoxic vasoconstriction. And we don't want to have that happen because we need plenty of blood flow to the lungs for picking up oxygen. If you wind up with too high a vasoconstriction in the lungs, you can actually have right-sided heart failure, known as cor pulmonale. There we go. Cor pulmonale, right heart failure. Ventilation perfusion mismatch. This happens in pneumonia, where we have an area that is well perfused but not well ventilated, and that is going to drop the patient's blood oxygen level. That's why the blood gases and the pulse ox don't read well. I mean, they're not in normal range when the patient has a big pneumonia. Make sure you understand the little a is arterial oxygen. The big A is alveolar oxygen. Little a, CO2, arterial, big A, alveolar. All right. Let's see here. When there's an increase in ventilation, the alveoli become enlarged by a larger volume of air moving into the lungs. This increases the pressure on the alveolar capillary membrane and more oxygen diffuses. You will also be doing that clinically when you add PEEP to the patient. So let me mention that. PEEP, positive end expiratory pressure, is one way that we expand the alveoli and get more oxygen to diffuse. And this is just a graphic of how that happens. The idea is, instead of using a higher percentage of oxygen, which we know can be toxic, instead of doing that, we use PEEP to expand the alveoli better, and that causes more oxygen to diffuse, even though we use a less high percent. Here's a little golden rule for you. If you can keep the oxygen percentage to 60 or below, we avoid a lot of problems, a lot of toxicity problems. So uh, PEEP is how we do that. You'll learn much more about PEEP in the courses to come. I don't see really anything that you need there. Okay, this is showing you alveolar CO2 and O2 on one graphic. That's an interesting graphic because what it does is it shows you how the VQ matching impacts ventilation and oxygenation. That's a pretty useful little graphic. Look, as the alveolar PO2 gets higher, the alveolar CO2 gets lower. Interesting graphic. pH. Well, that's the next thing you surely need to understand. It's the hydrogen ion concentration. It is the pH. And, a neutral pH is 7, but for us, arterial blood is normally 7.35 to 7.45. That's a pretty narrow range that nature wants our pH to be in. And most of our patients are there. They may have to be compensating to get there, but they do, in fact, manage to get in that range. If they get less than 7.2 on the acidic side, they may wind up on a ventilator. That's kind of maybe a key number to remember. pH lower than 7.2 may require ventilation, as in endotracheal tube and or at least non-invasive ventilation. Yeah. About 10% of blood to the lungs move past underventilated alveoli. That means there is a mismatch between the ventilation and the perfusion, about 10%. So our system's not perfect. It's really good and it works, the great majority of the time. COPD is associated with damage to the alveolar walls. We have less surface area. That's the key words to highlight for you there, less surface area, because so much of the alveolar surface has been destroyed. Cheyne-Stokes respiration, heart failure is the number one reason that happens. This is the rapidly increasing and decreasing ventilation, which we showed you a picture of earlier. And the cycle lasts typically 30 seconds to 2 minutes. Breathing gradually increases, then gradually decreases, and then there usually is a short pause before the cycle starts again. Okay, ataxic. What they're doing here is describing all those pictures that we found earlier. Ataxic, irregular rate and depth, just irregular rate and depth, often associated with stroke or trauma. Kussmaul's is the rapid, deep breathing, and the patient's breath smells fruity, or some people say like acetone, like nail polish remover, and that's because of the ketones in the patient's breathing, and that is very commonly in diabetic ketoacidosis. Cluster breathing, also known as BIATS, that's on your board exams, they call it BIATS. Rapid, shallow breathing followed by periods of apnea. Oh, here it is at ABG. Normal ABG, 7.35 to 7.45. CO2, 35 to 45. Bicarb, 22 to 26. Normally we say 26. Base excess, -2 to +2. Oxygen, 80 to 100. And saturation, 90 to 100. So those are numbers that you just need to know. You're going to be using them for the rest of your career, and you'll be interpreting a lot of blood gases. Ventilation control, alters the rate and depth of breathing, primarily based upon carbon dioxide and its effect on pH. You got various receptors and sensors out there which are helping us to try to balance things. Sorry, I got kicked off there. And under ideal conditions, the ventilatory process is not disrupted. It matches about 80%. That's the VQ ratio of 0.8. Let's mention that number one more time. Preferably, the body is able to maintain a normal pH, 735 to 745. Oxygen, 80 to 100. Saturation, 95 to 100. That's by the pulse ox. And CO2, 35 to 45. When ventilation control is disrupted, you get abnormal breathing patterns. And we mentioned Cheyne-Stokes, ataxic, Kussmaul, and cluster breathing. We might go back up real quick now that we've talked about those and show you the picture of them. That's where we started. I think it was about slide 20. There it is. Boom. All of those you need to know. Normal, apneustic, ataxic, Biots, Cheyne-Stokes, and Kussmaul's. All right, that concludes our chapter 10. That was a presentation I was given for uh, a medical conference. And that's it. You know what? Why don't we just continue with make this one recording and include chapter 11 as well? Let's just do that. Respiratory mechanics and lung function. Let's see how many slides this is. 62. All right. So let's just go ahead and talk about this, and then we'll be caught up for the week. I think you guys understand there's no way that we can cover in our 2-hour session all the material. So we have to do some of these recordings. And I don't mind doing it at all. So you'll just find these in the course. Static and dynamic compliance. You definitely need to understand that. Airway resistance. That's another key concept. A relationship among ventilation, lung compliance, and airway resistance. Hooke's law. Pressure volume curves. 3 patterns of gas flow. Laminar, turbulent, and some others. Explain the difference between positive and negative pressure ventilation. And conditions that may cause shifts in these various curves. There are certain waveforms that you just need to know, and we'll make sure you know those as you go through the program. But respiratory mechanics is the term that basically describes this whole process, the forces that allow the lungs and chest wall to operate effectively, keep the lungs inflated and ventilated. Lung function is the expression of the respiratory mechanics. And you are going to do something called a pulmonary function test, which you will learn very soon. And you'll also learn to interpret. Mechanics of the lungs and chest, springs working in unison, yeah, with counteracting pressures and forces. That's a good way to describe it. Several factors influence this. The relative compliance of the lungs, the relative resistance, both in the tubes and resistance to expansion. Compliance is the ease with which an organ system can be stretched. And we can talk about the compliance of the heart or the other structures, but definitely the lungs where we're most interested. So compliance you can think of as the change in volume divided by the change in pressure. Change in volume divided by change in pressure. And we'll show you how to calculate that. We've got dynamic and static compliance. Compliance is also known as lung distensibility. It's how easily do the lungs inflate. I bet you've noticed when you take a balloon, brand new balloon out of a bag, it's hard to get that balloon to start inflating. You really have to work to get it to start. But once it starts, it inflates pretty easily after that. So that's what we're talking about. That balloon right out of the pack is low compliance. But once the lungs are partially inflated, or once the balloon's partially inflated, it gets much better compliance. So there we go. That's just what I was mentioning. Compliance is change in volume divided by change in pressure. It won't let me highlight that because it's actually a picture. But at any rate, change in volume divided by change in pressure. So it comes out in the units liters per centimeter of water. And here's an example. Let's say you've got 500 milliliters of air that's being moved, which is pretty typical. Say many of our patients are 4 or 5, maybe 600. And the pressure involved is -5 and -10 at the end of inspiration. So it's a change of pressure of 5. So we've got 0.5 liters divided by 5 centimeters of water pressure, giving you a compliance of 0.1 liters per centimeter of water. Static compliance. Often static compliance is about 200 milliliters per centimeter of water. It is the pressure using, or the compliance level using the plateau pressure, which is a static pressure while air is not moving. Have the patient inhale, and then you trap the air in the patient's lungs and measure the pressure. That's called the plateau pressure and is used to calculate static compliance. Dynamic compliance is different because then we're using the peak inspiratory pressure, and the normal ratio for static compliance to dynamic compliance is 1:1. Let's see here, specific compliance, that's where we divide the compliance by the functional residual capacity. What the heck is that? FRC is the functional residual capacity, and that is the resting level at which the patient exhales to. The exhale to the FRC, there is air remaining in the lungs, and that is the reference point, if you will. So specific compliance is compliance divided by the FRC. All right, don't see anything there that you really need. Total compliance is compliance of the lung plus compliance of the chest wall. We don't actually use that clinically. We definitely use dynamic compliance clinically and static compliance clinically. This one we do not, but you just add them up, the lung and the chest wall. Okay, and we'll put that on a curve, and that's your first look at a volume pressure loop. Pressure about 10, volume about 8.8 liters, something like that. So using these curves, you can actually determine elastic work, non-elastic work, dynamic and static compliance. We'll do some calculations together on that. I remember your request that we do some practice calculations. I'm actually going to make note of that right here. Practice calculations. Okay. Do that on Monday. And let's see here. Oh yeah, the changes in compliance with different type lung problems. Increased compliance, more pliable lungs, and I would say too pliable, way too pliable. Emphysema, that's the trapped air of emphysema. Then there's a curve for normal, and then there's a curve for stiffer lungs like pulmonary fibrosis. So there really is a range of compliance that's good, and it can be too high or too low. Chest wall compliance, nothing much on there. Residual volume is a concept that you need to know. When you exhale as hard as you possibly can, there is still air in your lungs. That's called the residual volume. You can't get rid of it. In fact, we want some of it to be there, yeah. But when that residual volume gets too big, that's like emphysema, then there is less room for the patient to breathe above it. So chest wall volume and transmural pressure, looking at the residual volume. Elastic recoil, change in pressure divided by change in volume. So you might say that that is the opposite of compliance. It's the reciprocal of compliance. Elastance or elastic recoil. And there's the formula. That one I can highlight. All right. Total elastance is the elastance of the lung and the elastance of the chest wall. So that's very much, like we had with compliance. Total elastance, elastance of the lung plus elastance of the chest wall. Hooke's law, the movement or distance a spring stretches is directly proportional to the force or load applied to the spring. And that's what's happening in your lungs. Elastance explains the opposite action and reaction of compliance in an organ system. So that's Hooke's law. We don't really use Hooke's law clinically, but it's useful to know what it is. The inspiratory and expiratory arches in a pressure volume curve can be used to illustrate the differences in lung volumes. And this is a picture showing you that. Lung volume against change in transpulmonary pressure, inspiration, and expiration. Pressure gradients, that's a change in pressure per unit distance. And it's pressure gradients that really make things happen in the lungs. Pressure gradients from the outside atmosphere to in the lungs, pressure differences across the alveolar capillary membrane. This is, how things get accomplished in the lung. 1 atmosphere is 760 millimeters of mercury. We've used that number multiple times now. Pressures greater than 1 atmosphere or 760 are positive airway pressures. So, we're really referencing everything against barometric pressure. When we say it's a plus 20 pressure, it means 20 above barometric pressure. During normal breathing, airway pressures at the mouth and nose are usually 0. It takes very small amounts of pressure change for a healthy patient to breathe, and we're all very fortunate to, because of that. Pressures inside the lung do change in response to movement of the chest wall and the lungs. During a normal inspiration, the thoracic muscles lift the chest wall up, the diaphragm descends, and then a small amount of negative pressure is generated. I see the picture coming up, and that's going to tell the story. Transpulmonary pressure, and we see that throughout the lungs. That is what brings air into the lungs. The diaphragm drops, the thorax expands, a negative pressure is generated, and air flows in. It's a beautiful, simple design. Nature knows more about this than we do by far. And it's a very simple design where we can breathe effectively with minimal effort for 70, 80, 90, 100 years. It's remarkable. And then this is the calculation for that. Transrespiratory pressure is the difference between alveolar and body surface area. Transrespiratory pressure describes the pressure from the airway opening to the alveolus. So it's how much pressure change is there from the airway opening, whether it be just the patient's nose or mouth or an endotracheal tube, and the alveolar pressure. Transpulmonary is also called the alveolar distending pressure, and that's the pressure that actually causes alveoli to inflate. Here we go. Transpulmonary pressure can be calculated as alveolar minus intrapleural. We don't use that formula clinically either. Transthoracic pressure, pressure required to expand or contract the lungs, difference between transpulmonary and body surface. Airway resistance, friction of the airways and lung tissue to airflow. How much resistance is there to the flow of gas? In asthma, there is a great increase in airway resistance because the airways are narrowed in bronchospasm. There we go. I knew they were going to use the asthma example here, and it certainly is the most relevant one too. We use something called Heliox. I was just using that recently on a patient. It's a mixture of helium and oxygen, and that mixture of helium and oxygen is much easier for the patient to breathe if they have a very high airway resistance and narrowed airways. It saves people's lives. The Heliox allows the asthmatic to get through their attack and breathe effectively until the steroids can kick in, and then things could actually get better on a long-term basis. This is the flow we talked about briefly before. Laminar is smooth flow, not interrupted, not turbulent. It's easy flow and easy for the patient to generate. It generates lower pressure levels because it is so laminar. Hagen-Poisson equation is used to quantify the amount of pressure generated by laminar flow. And there's the actual equation. You'll never do that actual equation on a patient, but it's interesting to see that the factors are the airway radius The viscosity of the gas, that's why helium helps. The heliox, because it's so much lighter than air, is easier to move. And then also the length of the airway. Turbulent flow is erratic or choppy, and it's hard for the patient to sustain. It takes more work of breathing. Secretions can cause that. The spasm of the airway can cause that. And then there's called transitional flow, which is a mixture. So we've got laminar, turbulent, and transitional. A little of both, you might say. And then, oh, I love this. This graphic really shows you those straight arrows are laminar. Look at the crazy arrows going around turbulent, and then the transitional, some of both. Love that graphic. Reynolds number is a mathematical expression of density times velocity times the length divided by the viscosity. So there we go. Reynolds number is determined in that way, and it's velocity, viscosity, length or diameter of the airway. You won't actually calculate that on a patient either, but useful to know what it is. A low Reynolds number is more laminar. So we're hoping for a low Reynolds number. If it's less than 2,000, the flow is laminar. Greater than 4,000, the flow is turbulent. And in between, it's transitional. So we actually put a range on these laminar, turbulent, and transitional flows. Ventilation time constant. The time constant is airway resistance times compliance. That's what it is. Time constant is airway resistance times compliance. And then we give you some examples of how that ventilation time constant changes with various lung volumes. You don't need to memorize those. And there's a curve that shows you how the time constant changes based upon changes in pressure. Right. Restrictive disorders. Let's give some clinical examples here. Anything that makes the lungs stiff. A restrictive disorder is anything that makes the lungs stiff. ARDS, atelectasis, interstitial lung disease, pneumonia. It's quite a list. If it's not CBABE, it is restrictive. So that means I've got to tell you what CBABE is. CBABE is a list of the obstructive diseases, and it's all of them. Cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema. So here's what we say. If it ain't CBABE, it's restrictive. Those are the only obstructive diseases, and they take a lot of our time in our clinical practice. But everything else, like the list we just gave you, is restrictive. You might as well memorize CBABE. That'll help you the rest of your career. Okay. Don't see anything that you really need there. Pressure volume curve representing lung dynamics. Yeah, we've actually seen that before. It's the inspiratory and expiratory curve. Transpulmonary pressure against volume. That's actually a repeat, I think, of this slide we saw before. But here's something you definitely need to understand. If we want to improve lung mechanics and also want to improve oxygenation, we can do that with PEEP, positive end expiratory pressure. So we do that intentionally to expand the alveoli and get more oxygen in, but also sometimes we wind up with auto PEEP when the patient does not have enough time to exhale, and that's not good. We want to fix the auto PEEP, but we will use actual PEEP when it's appropriate for the patient. And almost any intubated patient should be on some level of PEEP. Here we go. This is lung dynamics. You notice the PEEP is above the zero baseline. This one doesn't have numbers on it, but I would say typically maybe 5 to 10 centimeters of water above the zero baseline. And it does most assuredly improve lung mechanics and improve oxygenation. A great thing is that you can use less oxygen because you've expanded the alveoli better. The high pressure at the peak of inspiration is called the peak pressure, peak inspiratory pressure. And the pressure when the patient exhales and airflow stops is called the plateau pressure. The peak pressure is used for dynamic compliance. Dynamic compliance. And the plateau pressure is used for static compliance. All right. And this shows it graphically. The plateau pressure is that line coming across below peak, but above the PEEP level. We have a PEEP of 5 here, but we have a plateau pressure of about 20 and a peak pressure of maybe 25. So that's a very useful kind of a practical example. Plateau pressure corresponds to the elastic recoil of the lungs and chest. Positive pressure ventilation is what we do with our, modern ventilators all the time. We are basically inflating the lungs under pressure, and it works, but it has some adverse effects that we have to be careful of. One of those is barotrauma from too much pressure. So what we've learned is that if we can raise the baseline with PEEP, we can ventilate the lungs more easily and avoid barotrauma. Negative pressure ventilation is creating a negative pressure outside the chest, like an iron lung used to do, and like something called a chest cuirass does today. Oh, there they mentioned the cuirass. Okay. Iron lung and chest cuirass. Wow. Exact two examples that I chose. So negative pressure ventilation, we don't do a lot of that these days. It's largely been replaced. But there's a picture of the iron lung, and wow, how cool it is to still be able to look at it and see how it works. Can also be a shell, as in a cuirass that goes around the patient's chest. Summary: ventilation is complex. Yeah, it really is, but you'll understand it. Respiratory mechanics, compliance, resistance, time constants, dynamic and static compliance. Stat is plat. That's directly from my first professor. Stat is plat. So plateau pressure is used to calculate static compliance. Peak pressure is used to calculate dynamic compliance. Pressure gradients are very important in what happens in the lung. Airway resistance is key in any condition where the airways are narrowed. And we can sometimes use a mixture of helium and oxygen called heliox to overcome very high airway resistance. Folks, we have covered the last 2 chapters for this week, and I'm going to go ahead and post this in the course.